and welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley, and I am TMA Senior Manager of Patient Education, Support, and Advocacy. Today, we have the honor of speaking with Dr. Lesley Saketkoo. Dr. Saketkoo is Director and Founder of New Orleans Scleroderma and Sarcoidosis Patient Care and Research Center, which cares for patients and conducts research in rarer multi-organ system autoimmune diseases, of which myositis is a primary disease. She is currently co-director and co-founder of UMC Comprehensive Pulmonary Hypertension Center and interstitial lung disease clinic programs with Louisiana State University and Tulane University Schools of Medicine. In 2018, she was honored with Doctor of the Year from the Scleroderma Foundation, a condition that has many similarities to myositis. She is a medical advisory board member of TMA and has been chair of the International Myositis Assessment and Clinical Studies Group IMAX Planning Committee and remains heavily involved in IMAX. In addition to clinical trials in myositis, her focus is exercise as medicine, which is dedicated to developing guidelines and educational products for patients with myositis and the clinicians caring for them. She is a clinical researcher recognized for her work in clinical trial design and identifying patients' priorities in life-threatening autoimmune illness, including pulmonary hypertension and pulmonary fibrosis, and developing research tools with patients, including targeting self-management strategies like yoga, dance, and singing for lung health rehabilitation, as well as mindfulness practices. Doctor, welcome and thank you for being here. If any of you in the audience have a question, please type it in the Q&A box at the bottom of your screen. Before we start today's Q&A, Dr. Saketkoo will take a few minutes to share her work.
Rachel, thank you so much. It's really wonderful to be here. As always, I love being with the TMA and all the great work that you do. My work, pretty much is driven, like many of my colleagues, by patient priorities and patient-centeredness. That means taking cues from what's important to patients and traveling down those roads and trying to present options that may be solutions. And in one large area is related to exercise as medicine. And in that regard, both in myositis and scleroderma, and to some degree in sarcoidosis, we've been looking at exercise as medicine. And I'm just so thrilled to work with so many wonderful, wonderful colleagues and patient research partners that are paving the way forward in terms of identifying how exercise changes disease, impacts disease activity, and impacts patient function and quality of life. So, but on a molecular level, it's remarkable what we've been learning, and then very importantly, hearing what patients have to say about their experience of exercises, because exercise and different types of exercise, because we need to understand exercise from the lens of a person living with a health condition in order to be able to address really important issues like exercising, when is exercise too much, and what is a patient's experience after exercise, and what distresses a patient, so we can be able to understand the concerns of safety and for patients, and in terms of expectations. And even though I believe wholeheartedly, and the research is demonstrating that exercise is in fact a disease activity modifying intervention, that an important expectation is that it is very, very, very unlikely to replace our important pharmacotherapy such as mycophenolate or rituximab, but it is a strong ally. There are some studies that have shown that on exercise, patients were able to reduce steroids. So that's very positive. Because we really try to get patients off steroids and onto another bridging medication. So that's one part of what we do, and that I'm really thrilled about working with these wonderful people. I also spend a lot of time in interstitial lung disease and pulmonary hypertension, and working to understand living with these conditions from a patient's point of view, especially in addition to clinical trials in these conditions. You know, one of the umbrella thing that I would probably say about my work, Rachel, is that the work is geared towards improving quality of life. And so that folks, we might be able to develop strategies that even if we don't have a cure, and a cure for these diseases are, you know, they're not nearby, right? Everything that we do is really trying to cope and live with these conditions. But in addition to pharmacological therapy, there is really impactful streams of interventions that are non-pharmacological that can really transform how a patient feels about their life and the ease with which they can get through their workday, their home life, deal with fatigue, be able to be in touch and manage difficult feelings and concerns as they arise. And this is where mindfulness comes in to a good degree. It doesn't necessarily change a situation, but it helps us maybe better navigate through it so that we can be better communicators and stay tender and communicative with the ones that we love. And also be able to recognize what we need to be able to be more functional and to be able to state our needs. So that's it. I mean, I know.
Well, thank you
You're
so
supposed to
much.
redirect me if I'm going off the rails or too far.
No, it's all wonderful. Thank you so much on behalf of TMA and our audience. Thank you for the critical work you do. We will now begin the Q&A portion of the webinar. Thank you for submitting questions. We will get to as many of them as we can. You mentioned mindfulness practices. For someone who's new to that word, mindfulness, what do you mean? What do you mean?
Well, that's really an important question because we use it sort of like it's vanilla ice cream, right? And almost everybody and their uncle is learning how to teach mindfulness. So, but really basically what mindfulness is really taking the time to listen to yourself. It's befriending your mind, befriending yourself for all your limitations and your strength, and being able to rest with oneself. And even though that we might feel like we're about to go off the rails because we're absolutely embarrassed or ashamed or mortified for some reason or other, it helps us. It's a practice that helps us remember that we're human and that our friendship with ourselves really has to come first. And it's basically, should we just do like 30 seconds of a mindfulness exercise?
Oh, sure. Go ahead. Yes.
There's just 3 components. And the components are just letting your attention rest on an object. And then, we'll go through this. And then when the meat and the gorgeous part of this is this next step, which is recognizing when your mind is wandering, noticing when your mind is going off, because that's what minds do. And this is really where the meat of the heart of the exercise is being practiced. Because sometimes our mind goes off and we don't even know that it has, and we're just on this train wreck of one thought after another that's really making us feel increasingly uncomfortable. So this is why this second part, just noticing that your mind goes off, is really important. The third part is just smiling at yourself and inviting your mind to come back with self-kindness, not with as a punitive nature, like, oh, I messed up again, but really as, oh, you did it again, just like as if you were like a little puppy. That's how we have to treat ourselves in order to kind of get better, I think, is to treat ourselves as little puppies. So if we all if everybody's able, a good way to do this is resting one's hand on in your lap so that your hands are sort of on your belly, or you can feel your abdomen with your forearms, for example. And then just allow your eyes to soften and gently close. You don't have to close your eyes. They can just go to a hazy gaze in front of you, no problem at all. And then you just notice that contact. Allow your mind, your attention to rest on that sensation of the contact between your belly and your hands, or your belly and your forearm, or the sides of your body and your forearm, whatever it is, your upper extremity and your torso. And you're going to notice that sensation changes in intensity as the air moves in and as the natural breath moves out. Just allow our attention to gently rest on this dynamic, changing sensation like a massage. And it's as if the mind is just resting on the sensation that's created by these tides of the breath as air gently finds its way in. Then the air finds its way out. Now you're going to notice that your mind wanders and moves away from this changing sensation, this massage sensation. No problem. No problem. You just smile at yourself and you just invite your mind to come once again and rest upon that changing sensation between your upper extremity and your torso. And there's no right and there's no wrong. And just allow 3 more breath cycles. And when you are comfortable, you can gently let your eyes softly open.
Thank you so much. That was just relaxing and I appreciate it. And I know that mindfulness has a lot of benefits for people, especially if you're dealing with chronic illness. So thank you for demonstrating that for us. Let's go back to exercise. You talked a lot about that in your intro to your work. We had several questions come in about exercise. One person in particular asked, why do I have so much pain after I do my daily exercising? Sometimes I actually get wobbly at the knees.
Yeah. So there's a number of parts to this question, and there's information that would help to better answer the question on a personal level. I will just start by saying that there has to for muscle to repair itself, and this is going to answer questions that people have about CK elevation, creatinine kinase elevation as well. So when we exercise and muscle remodels and repairs itself, there's going to be a burn. There's going to be a slight burn. And also at the same time, because muscle is remodeling itself, there's going to be an increase in creatinine kinase. So, and that's why athletes, after they do a marathon, etc., if they got blood tests straight away, you're going to see that their CK goes up. And we've known that. We used to think that was a problem. We used to think that, because sometimes if people overexerted themselves, then the CK went up and it stayed up, and it was a problem. And that is a problem. But for the transient elevation of the CK is not a problem, and it's reflective of muscle use and muscle trying to intensify its mass where it's being used. Because so the muscle's actually trying to respond to what it believes that the human being wants to get better and stronger at. So it's trying to be responsive to that. It is really important, though, to notice how intense one feels. Pain, what kind of pain? Is it joint pain? Is it in the knees? Is it these myalgias? And how long does it last? It's not unusual for after an exercise session for folks to feel wobbly. This happens in people without myositis as well after they do something a little bit more intense than they're used to, like a yoga class, for example. But I always feel that it's really worthwhile if folks have any concerns about safety, and to have a session or two with a physiotherapist, let them know what you're doing, so that they can advise. They can, first of all, analyze what kind of pain you're having. Where is it? Repetitive joint pain is not good. And if there's joint pain, that needs to be stopped, because that means that the exercise is not being implemented correctly, and that too much force is going into the joint as opposed to being picked up by the surrounding muscles. And like I said, some myalgias or burning during exercise and shortly after exercise are not problematic. And we're going to be addressing some of these issues in our guidelines for safety and exercise in myositis that is coming out. And the other thing that I also want to share is, I know folks are very interested in workouts that are safe for people with myositis. And so part of what our group is going to be doing, or our IMAX ICERS group, which is the International Collaboration on Exercise and Rehabilitation Guidelines, which is in collaboration with the TMA, is we are going to be providing educational modules and workouts that are safe for folks with myositis. One other thing that I would say is, going back to the mindfulness. Sorry, the sun is coming in this way because the sun is moving, so might look a bit weird. But one thing that I will say is, we exercise, when done with kindness and a cultivation of pleasure, is a mindfulness exercise. And then developing that mindfulness muscle when we exercise, and that pleasure muscle when we exercise, that helps us be more aware of what's safe for us, what feels right, what doesn't feel right. There's sometimes that pain that's a little bit of pleasure, and most people know what that is. Like when you do a luxurious stretch, you get that kind of like deep massage sort of feeling. But again, it should never be in the joints, and it shouldn't, it's hard to say people are different, but 24 to 48 hours afterwards, if your muscles are still hurting, you also want to make that may have been too much. And one thing that's really very important is staying hydrated, because we need to be able to clear toxins after we exercise. We need to stay hydrated, and we also, and this is the same for like when we get massaged, right? The massage therapist will always say, drink plenty of water, when you leave. There was one more thing that I wanted to say. I was going to bring up water exercise, because in light of this question, So water is blissful. It feels good for so many reasons. It's buoyant, it holds us. We often are able to do more in the water. We often are able to be more flexible in the water. We feel safer in water that's not too deep because it holds us. And we can practice balance exercises, and we could do and it provides resistance. So we really can get a terrific workout, more so than on land. The other thing that that water is that water is a conduit for temperature. So it wicks away our combustion, the heat that comes from our exercise combustion. So we're always feeling really good, and we sometimes don't notice how much we've exercised because the water makes us feel so much more comfortable. Sorry, and move around a little bit so it's not.
Fine.
So we don't. So it's really good when one is beginning to do exercise in the water, to have a good gauge of that, and maybe, if it's at all possible, maybe to get initiated into that with a physical therapist or occupational therapist. But it feels so good, and it really is such a wonderful medium, an environment for accelerating both balance, coordination, deep coordination, flexibility. It feels great on the joints, and the resistance. It's like a whole body resistance.
We have another question that came in from the Q&A. How do I balance exercise and weight gain? I need to exercise, but I also need to gain weight. It seems like I lose weight or can't gain weight when I exercise. How do I do both?
So interesting. So when muscle weighs more than fat. So the question is that the person, they feel that they're underweight, right? Is that the issue?
Yes.
Okay.
Apparently, we're going to assume their doctor says that they're underweight.
Right. So it's super important to focus on muscle mass. I think gentle exercise is warranted if one feels frail. So when someone says that they're underweight, there's a question of whether they are frail or feel vulnerable. And one of the most important things to move out of that frailty situation is exercise, no matter how gentle, and developing muscle mass. Exquisitely important is, again, balance and coordination. And it's hard to know because from one question what's going on with somebody, but if there's also an issue with osteoporosis because one is lost significant amount of weight, or there's questions regarding nutrition, these situations have to be addressed. Muscle mass, though somebody does have osteoporosis, can be done safely, and there's exercises. When we intensify and build mass over bone, that bone underneath intensifies, fortifies. Exercise fortifies bone health. In terms of nutrition, I think many of us feel that referral to nutritionists have been really underappreciated and underutilized in people with autoimmune diseases. And sometimes it should be, we need to speak up for ourselves and say, do you think I could get a review by a nutritionist or get some support from a nutritionist? Because without appropriate protein and a balanced diet, it's going to be very difficult to gain muscle. That's the other thing. You want to make sure that you have that nutritional profile in terms of your diet, and that it's going in the right direction. in order to be able to build muscle mass.
Have you ever worked with blood flow restriction therapy? Do you have an opinion on it?
I haven't done it, and I haven't sent anybody for it. There are some trials. Dr. Diedrichsen, who is coming on to the Myositis Association Medical Advisory Board, she's done studies in this, and it looks like it's promising. It's not very well tolerated, and oftentimes it's not feasible for patients to do on their own. And not tolerated because of the pressure, but as long as it's done under supervision, it seems that there are promising implications for developing muscle mass.
Thank you. We had another question about ILD, actually. Could people diagnosed with dermatomyositis and interstitial lung disease actually have lung sarcoidosis instead?
Well, that's interesting. Lung sarcoidosis tends to look different on the whole. I think as clinicians that are seasoned at a myositis center and at a sarcoidosis center, these folks always, generally, I should say, keep their minds open to that this could always be something else. The difference between dermatomyositis and sarcoidosis is that oftentimes somebody with dermatomyositis will have antibodies that are consistent with or a muscle biopsy that's consistent with dermatomyositis. And dermatomyositis, again, the pattern in the lung tends to look different, though, there are outliers, and tends to behave differently. Sarcoid is not usually a rapidly progressive, rip-roaring lung disease. It tends to be more on the indolent side, whereas some phenotypes, some types of lung disease in dermatomyositis tend to be more progressive, and the pace tends to be quicker. Also, lung biopsy can often help, sometimes not, but if there are granulomas on a lung biopsy, that can lead us in that direction. We generally have a different picture on lung biopsy of or several different pictures on lung biopsy of a patient with dermatomyositis related interstitial lung disease. So,
speaking of diagnoses, when would you recommend that someone get a second opinion?
That's a really good. First of all, if you're being left on prednisone for too long,
What's too long on prednisone?
Yeah, that's a really good point. That's a really good point. Well, and I'll tell you, most of the colleagues of mine begin immediately with discussions of bridging prednisone and talking about other treatments straight away, and that prednisone is really a bridge. It's not the answer. It's something to immediately dampen the fire. But we need to bring on board other medications, usually that that allow for us not to use steroids. In dermatomyositis and polymyositis, necrotizing myositis, these are not diseases that usually are self-limited, meaning that they're going to burn out on their own. They usually require a fair amount of dampening over time with varying amounts of aggressivity in terms of therapy, but prednisone carries a lot of damage to many organ systems, including the muscle as well. And so one can develop a steroid myopathy because of being on steroids for so long, where you lose muscle mass, you get weak. I mean, I think we're moving in that direction where hopefully most physicians are not simply starting prednisone, but very soon after, if not on the same day, starting something else to help that other medication, whether it's mycophenolate, methotrexate, or if somebody has very severe disease, starting straight away with rituximab to rescue that person. It tends to be now the paradigm of approach to steroid spare. And the other thing that I do want to say is that none of my colleagues that I respect so much they would only welcome a second opinion. We all recognize that these diseases are very complex. And none of the colleagues that I really respect would never not welcome someone to get a second opinion, because the patient's comfort is so important. And if it's reassuring for a patient to go to somebody else at another center, I think that is something that should be supported, because that patient is not just their muscle and every other physical manifestation, but the patient is also their psychological health. And if part of that is being reassured by going to someone else or expanding the conversation, discussing another aspect, that should all be accepted with open arms. And that's how probably you have a good specialist. The other thing that I want to say, and I think we're certainly moved towards this in scleroderma and in sarcoidosis, that we really encourage patients to be seen at centers. And we are, as my understanding of TMA, is really supporting this concept as well, that patients are cared for at recognized centers where there's people with clinicians with experience guiding general rheumatologists, general pulmonologists, general dermatologists, general gastroenterologists, so that you may have more than one rheumatologist or pulmonologist on your team, but everybody feels better because at least one of those people guiding care sees myositis or one of these rarer disease on a very frequent basis, on a daily basis. So that makes everybody feel better. So we're sort of moving to this paradigm of concurrent care. And I think the Myositis Association is too. And failing that, I know the Myositis Association is absolutely dedicated to educating patients about their illness, their manifestations, red flags, what need to be looked for, and extremely dedicated and to providing granular information to general clinicians, whether they're rheumatologists, pulmonologists, cardiologists, gastroenterologists, occupational therapists, physical therapists, on how to care or implement treatment for patients if that patient can't come to a myositis center.
Thank you. We've got a question here about, from someone with overlapping conditions. She has dermatomyositis and scleroderma, and how can she tell which symptom is caused by what? How can she differentiate between DM and scleroderma?
Well, I'll tell you that I try to get my patients not to focus on so much on that, because which is what, because we'll drive ourselves crazy trying to figure out if it's this, if it's that. We're experiencing one autoimmune entity, and sometimes it behaves like this, sometimes it behaves like that. Oftentimes, scleroderma and myositis are treated similarly in terms of the manifestations of these health conditions. And I worry that folks may be expending a lot of energy that they could be using to have peace or something else, and worrying about which is getting worse and what is getting worse. I tend to look at these diseases and try to get patients to look at them in terms of their manifestations. And some of these manifestations might mean that disease activity is progressing. So for example, interstitial lung disease, if your forced vital capacity is diminishing over time, that requires treatment, regardless of whether it's driven by dermatomyositis or scleroderma. And that's one of the reasons that going to an expert center or a specialty center it is really helpful. And then then that would require more treatment. But then there's other manifestations like Raynaud's, for example, which is maybe treated with counseling and strategies, preventive strategies, so it doesn't get worse. Or if you're having a flare, this is what you want to do. And this is common to most of these health conditions, regardless of which one we call it. So trying to address the manifestation is probably how I would encourage folks to look at their health condition.
Speaking of manifestations, we have a question submitted about a symptom, increased spitting from mouth. I am either totally dry or too much saliva. It seems like my mouth is shrinking. Is there anything that can be done for that symptom?
So it sounds like there's a number of things here going on. The question seems to hold a component of the mouth getting smaller, which sounds to me as though it could be there a scleroderma component, like a mixed connective tissue component. And then there's this there's two other symptoms that are described. One is dryness, and then the other one is hypersalivation. So, and one thing that I will just say right here is that many people with autoimmune diseases have dry mouth. And it's not necessarily quote unquote Sjogren's, but it is a dryness of the mouth that's related to the autoimmune disease. And sometimes we often say, oh, somebody has Sjogren's, meaning that they have dry eyes or dry mouth. So, and then that upsets people. But 20% of people with rheumatoid arthritis have these symptoms. So it's part of the autoimmune phenomena. Sometimes it gets better with pharmacologic treatment. And sometimes it gets better because we're just more cognizant of keeping our mouth wet. And so there are self-management strategies for that. One thing that I will say is that if folks do have issues related to oral health, such as mouth dryness, it's really important to try to ease into a regimen of mouth care twice a day with brushing one's teeth. I'm a proponent of flossing if one can. Not everybody can floss, or a water pick, and then using topical fluoride as well. So in addition to the fluoride toothpaste, fluoride topically is really important and recommended by the American Dental Association for people with Sjogren's or persistently dry mouth, because that prevents dental caries. I will say that additionally to fluoride, that's being tested more and more and may even be more beneficial than fluoride, is hydroxyapatite, which is similar to fluoride, but it's a smaller structure and it fits in the cage of the tooth structure so that it repairs the tooth more smoothly, it seems like, from these studies, and it also tends to help with sensitivity. I will say that there are vascular components to diseases like myositis and scleroderma, and so their patients can get recession of their gums, and for that reason, circulation, facial exercises, singing, humming, and exercise in general has been shown to increase salivation of the mouth and possibly circulation to the mouth. So because exercise helps with whole body circulation, and then when you focus in the mouth area and with facial exercises or oral exercises, mouth exercises, that helps to bring more circulation and all the good things that circulation bring to the mouth. There haven't been any studies, but to me, it's an area of great interest because many of our patients experience dental changes, shifting structure of their oral cavity, and tooth loss. And there really hasn't been any studies that I know of, even though there have been interest in looking at exercise to help alleviate these issues. Regarding the hypersalivation, if somebody has difficulty managing their secretions, maybe because if their mouth is changing so quickly and getting smaller so quickly, and their tongue is learning how to behave in a new, smaller environment, it can interfere with swallowing sometimes, and it can interfere with managing secretions, like swallowing our secretions, because we produce lots and lots of saliva each day, but we unconsciously, without realizing it, we're swallowing and we're managing these secretions. The other thing is that if you are having a lot of secretions, the other thing to think about is, do you have, and to ask your doctor is, do they think you have any features of autonomic disease, autonomic involvement? And what is autonomic involvement? The autonomic nervous system can sometimes be involved in some of these conditions, especially if somebody has Sjogren's disease. These diseases do impact people neurologically. And we think that maybe it's under-recognized in many of the autoimmune diseases, this autonomic involvement. Autonomic involvement is involvement of the nerves that deal with relaxing the gut, letting the body salivate, slowing the heart rate or increasing the heart rate. It's the nervous system that helps manage fight or flight symptoms, and also to help us calm down, the opposite of fight and flight. And so hypersalivation, or even from your nose, or heart fluttering, or sometimes feeling dizzy, having dizzy episodes, or these things can be related to what we call dysautonomia, which is involvement of the autonomic nervous system. So it's a good thing to bring up. And the other issue that related to this is also exercise. That if you have dysautonomia, one may want to understand to what degree they have it, so that they're not allowing their heart rate to get too fast, to the extent that it's not controlled and responsive, and it makes somebody feel dizzy, or even faint. So that was a really important question that opened, even though I know I did not answer specifically to that individual, it brought up a lot of important issues related to living with an autoimmune condition like myositis, and exercise with myositis. That was a great question.
You mentioned self-management strategies, and we had someone that read your bio and was interested in some of the things in there. Can you speak about some of these self-management strategies that you suggest for patients with myositis? There's yoga and dance. You've got singing for lungs and muscles. Is there a way to strengthen hands, such as knitting or playing a musical instrument? I mean,
Yeah.
Can you speak to that?
So, can I just take the hands first, because the hands are so important. In scleroderma, we are looking at trying to get the hand elevated to the status of a vital organ, because the hands get so damaged. But and the other thing about that is that we know that and this is true of myositis, we think that early intervention with occupational therapy and hand exercises can protect hand strength, hand flexibility, and function. And anything that we can do with our hands, the better. And the variation of things that we do with our hands, playing a musical instrument, going from knitting, and moving back and forth. The more tactile we are with our hands, beyond just typing, the more we're varying the performance environment of the hands, and just like the feet, the hands become more responsive in different ways, and perform better in different situations. So cooking, chopping, even if it's difficult, to continue even slowly, or while you're kind of recuperating, if you had a recent flare, to just gently keep up those activities alongside your loved ones that might be doing the lion's share of that type of work. But the more variable opportunities for function, different types of function and activities we give our hands and our feet, the more responsive and strong our hands will be for us. So I'm really long-winded today. I'm so sorry. Okay, so going back to, so one of my videos, which is not a high production video, but I think it's, so the production, I wouldn't give it an A, but the content I would give an A+. And that video is called 331, and I might have shared it with folks before. And what it is, it's an exercise. It's an aerobic exercise combined with a little bit of strength. 3 minutes of moving arms, 3 minutes of moving your legs, and 1 minute of getting up and out of the chair. But the way you practice it is with a mindful component, feeling the air on your skin. Even if you're not feeling it, you're listening. You're listening with your skin as you're doing this exercise. And the same with the legs. This exercise, as I mentioned at the patient conference, can be done lying down, can be done sitting, and can be done standing. And but what it does do, I hope, what it does, and I've gotten nice feedback from patients who we've had to use this instead of pulmonary rehab, because to get people bulked up for lung transplantation, for example, so they could be good candidates. But what I have heard is that it has helped them find the pleasure of exercise, and it has helped them gain better balance, coordination, and strength and function. So So
Yes,
yeah.
you've answered most of it. I don't think you talked about yoga. Did you
Yes,
touch on
okay, I'll
yoga?
talk a little bit about yoga. So gentle is good. We always should choose somebody who knows what they're doing, because everybody and their uncle is a yoga teacher now. So you want to try to be with the teacher, even if they're online, that know what they're doing. Can I put somebody's name in the chat that I think folks would really like? I can do that.
We have chat. We don't have chat enabled. I'm so sorry.
Oh no. Okay. So the name is I put it up there. Jackie Knit. JAKINETT. And she is one of the premier yoga teachers in the world. She has a free class online on Fridays. She is in California, and she teaches yoga as a physical therapist would, and with a vision to re-educating the muscles and the body, so that the muscles hold the bones in better alignment. Um, so it's Fridays at, I think, 10 a.m. if you're in California, 10 a.m. California, which would be noon for Central Time, and 1 p.m. I believe East Coast time. It's a 45-minute class. It's gentle. It's free.
And again, that's Jackie Nett,
Yeah,
Nett. All right.
JAKINETT. She is, and I've trained with so many people in this world, and she is phenomenal. So this class is a gentle class, and myself and other teachers go to this class because we learn so much about teaching. That's incredible.
Well, thank you so much for that referral. We've got about 8 minutes left. Someone in the Q&A function wanted you to circle back to, and let me see if I can say the word right. Dysautonomia. Could you talk about that more? Describe it a little bit more?
So dysautonomia, it can be, so if we think about fight and flight, so we have the, we have a central nervous system, right? That that through which we feel the world around us. We have the central nervous system, we have the peripheral nervous system. The central nervous system is the brain and the spinal cord. And out from the spinal cord and some areas, and also sometimes areas of the brain, we have the peripheral nervous system that feeds the body outside of the skull and outside of the vertebral column, which provide us with being able to move, being able to feel sensation, and sends messages. The brain sends messages through this system, and the peripheral system feels the world around it and sends messages to the brain. Part of the peripheral nervous system is also the autonomic nervous system. That's what kind of modulates neurohormones that make our heart race, that slow us down, that
so what are some of the symptoms that, or manifestations that would tell a person, hey, I might have dysautonomia?
Okay, so in the last question, the person had hypersalivation. If you have running nose, that's one side of it too, or a lot of tearing eyes. If you have fast heartbeat, palpitations, I'm not saying that just because you have fast heartbeat, palpitations, or a running nose, you have this, but if it's a chronic problem, it's worth considering. Diarrhea. On the flip side, you can have constipation. If you have a fast heart rate and are feeling dizzy or faint, that's another complication. So it's worth so
Getting
if you're
it checked
having
out.
these, it's just worth bringing it up and asking, I heard about this, and does this sound like me? Does this sound like that could be me? And usually we rule out other things first. Unless of course somebody has fainted after having palpitations, but we usually do kind of think about other things first. And some of these symptoms can also be related to like thyroid disorders, for example, or even diabetes. So there's preliminary testing that we general testing do anyway.
Okay. That sounds good. Thank you. We're getting close to the end. What advice do you have for myositis patients to improve or live a better quality of life?
Love yourself. Really, really make friends with yourself. That whole mindfulness thing, that triangle, that also applies to when we feel frustrated with ourselves, just to notice we feel frustrated and then be just okay, just invite ourselves to be nice to ourselves or soften to ourselves, learning how to be friends with our mind and developing a friendliness with our body through these mechanisms. Learn as much as you can. Talk to other people. If you're uncomfortable with your physicians for any reason, it's important to express that. And you should never feel bad about what, like we talked about before, second opinion. It's hard to live. It's hard to be somebody living with a chronic illness because it's psychologically so complex. And we can really beat ourselves up and accept less because we don't want to hurt other people's feelings, and we don't want to be the one to hurt other people's feelings. But anybody who's part of your care team will understand if you question something. And again, that whole concept of a second opinion. So learning as much as we can, advocating for oneself, learning about self-management, and doing things that feel good for us. And we all tend to value what we can do for others, but as kind of being so part of our self-identity. But honestly, if we're not good to ourselves, we just can't perform well for others. It taxes our fatigue. It taxes our psychological capacity, even. So ironically, looking after yourself, you get more mileage for others.
Thank you so much. Dr. Saketkoo, we really appreciate you participating in today's webinar. And it's been an honor. So thank you.
Rachel, thank you. It's an honor to spend time with you. And I'm always so grateful for the work of the Myositis Association. And it was a wonderful conference, met so many wonderful people, really touched my heart. Thank you for all you do.
Of course. Thank you. All right. Well, thank you in the audience for tuning in today. Please tune in next Thursday, October 27th for an empowerment clinic on TMA support and affinity group program. Then the next Ask the Doc webinar will air on Thursday, November 17th from 6 p.m. to 7 p.m. Eastern Time, when we will host physical therapist Dr. Lindsay Alfano. Hope to see you there. For TMA, I'm Rachel Bromley. Good night.